Welcome to the Navigating My Crazy podcast. I'm Shayla. Navigating My Crazy is a weekly podcast created for moms trying to balance life, family, purpose, and wanting to improve their mental wellness. Our goal is to inspire conversations necessary to end the stigma associated with mental health and the unrealistic societal expectations related to being a mom. But most importantly, to create a community so that no mom ever feels alone as we all navigate this crazy thing called life together. Let's start this show. So on this week's episode of the Navigating My Crazy podcast, we are chatting with Dr. Christopher Holloway. She has been instrumental in being an advocate for maternal mental health. And one of the reasons that I reached out to her for this interview is because I've had several moms or potential moms reach out to me saying that they really related to my message, but they couldn't conceive or that they had actually miscarried or experienced infant loss. And so I reached out to Dr. Christopher because she is an assistant professor and the founder and director of New Vision Counseling Center, LLC. She's also the founder of New Vision Consulting and Training, LLC. She's a licensed professional counselor, a national certified counselor, and she's certified in perinatal mental health. She works with minority women experiencing infertility trauma, birth trauma, pregnancy and infancy loss, and issues related to maternal mental health. Dr. Christopher Holloway presents regionally, nationally, and internationally, and she focuses on African American and mental health, the psycho-emotional impact of infertility in the African American community. Also, which I totally understand, the strong Black woman syndrome and generational trauma and so much more. So thank you so much for joining us, Dr. Christie.
Thank you for having me. I'm so excited to be here.
I want to start off with this question because there's such a wide range of mental health issues and factors. Mm-hmm. What made you choose to focus on maternal mental health and infertility?
Right. So one of the things that you said, we have a lot of my clients were coming in. They may have had experience losses or trying to get pregnant, dealing with so many things as it relates to being a mom. I saw that I was seeing that more often and they didn't know where to go. And then also my own personal experiences after I had my twins with some postpartum related issues and then infertility as well. It became one of those things that I was drawn to, or I was supposed to be working with or working in from a professional standpoint from the clients that I see, and then also just with my own experiences. And so I knew there was a gap or a void with trying to find a clinician, even knowing that you could speak to a clinician, not even really knowing what postpartum or maternal mental health issues even looked like, because a lot of times we just write it off. My thing was, well, I'm just, tired. I got twins. I knew that there was a need and needed to figure out how to fill that need. So that's what got me to this point.
Right. And I saw that you recently got your doctoral degree, correct?
Yes.
Correct.
Yes.
So congratulations. That's amazing.
Yep. Last year. Thank you.
So as far as infertility and having these issues, what are the mental health impacts? What do you feel really needs to happen, or what information do you feel that needs to be shared?
Right. Well, first, let me give the audience or the listeners like a definition of what fertility is, because I also think that people don't know. And so they're out here struggling, or maybe not even struggling, just trying to figure out why they're not pregnant or not getting pregnant. And so infertility is the failure to achieve pregnancy or maintain pregnancy or go to a live birth after 12 months of actively trying to conceive. For women that are, or couples or folks, whoever, that are 35 and under, it's 12 months. Once you hit 35, the medical literature says that we are advanced maternal age. After 35, though, is 6 months of trying. And so again, that can look like not getting pregnant or not being able to carry a pregnancy to term. So you're not having live births. It can look like recurrent miscarriages, things like that. And so you have basic or primary infertility and then also secondary infertility, where you may have had a child prior and then now you are struggling to get pregnant again or to carry to term and have a live birth again. And so a lot of times people don't not even know. I talked on this just last Saturday at a forum, and someone was saying, I had never even heard of secondary infertility, but I knew I was struggling all of these years to conceive again and couldn't figure it out. So that's the definition of infertility. And so the mental health piece that comes with that, it can look, depending on a person's desire to become a parent. I know your podcast deals with moms, so I'm just going to focus on moms because I also want to make it clear that infertility also happens in men. Mm-hmm. Okay. So I'm going to focus specifically on moms, though. Depending on how this person wants to become a parent, how long maybe they've been trying, what are some of their goals, it can take on various forms. So for some people, it may be, okay, well, I didn't get pregnant this month, next month, the month after, and I'm sad, but, I'm still kicking it. I'm okay. Others, it can look or start to manifest in depression. Because sometimes in my experience and in the women that I work with, a lot of the thought process is what's wrong with me? My body is failing me. Why can't I do something we're naturally supposed to be able to do? Right. This is what women do. Because culturally, some women, their identity, so to speak, or their value is in motherhood and, producing an heir and things like that. And so when you're struggling to do that, that can be very, very hard and hurtful. So the depression can come with it, but also the grief and loss. You think about someone who is trying to conceive and whether they are actually having physical reproductive losses in the terms of miscarriages, or even just the grief of, hey, I thought, I always say your mama tells you, don't you have sex now because you're going to get pregnant. That's all right. When you get ready to have sex and get pregnant and that doesn't happen, right? It's like, well, what's going on? And so now you're grieving the ability to naturally, so to speak, or to lay down your partner or whatever, have sex and become pregnant. So that's a part of loss too. This what we think should be this natural process. So you have to grieve even what's not happening in those terms. So there's the grief and loss, there's the depression, the anxiety. Is it this going to be this month? Is it this? What's going to happen when I take this pregnancy test? Do I want, pregnancy tests now are like so advanced. Back in the day, it was like those 2 lines, right?
Right.
A blue dye test and a pink line. You get your 2 lines. Mm-hmm. I remember the first time I took a pregnancy test that actually had the words. And for me, that was more devastating than not seeing the 2 lines. Because here it is right there. Nope. Whereas them 2 lines, you can be squinting and looking. Like,
right. It's faint. Yeah.
There, let me try another one. And, you holding it up to the light and things like that. Especially if you're a part of the infertility community, all types of stuff start going down. We, trying to do all types of stuff to see that second line. So anyway, though, that's where the anxiety can come in. What does my partner think? Is my partner going to stay with me? What, maybe there's some pressure from family. They may want a grandbaby, or it's been 5 years, whatever it may be. So you have this anxiety. Is it time for the family reunion? Is it time for holiday gatherings? Are people going to ask me if I'm pregnant? Which cousin or family member is going to be pregnant now? Right. And everybody, all eyes on me, right? So you have the anxiety, but then I also talk about the trauma or the traumatic piece that can come too from infertility. One, if you're having several losses, that can be the part of, and I won't go into the whole full clinical part of it in clinical definition, but when we talk about like post-traumatic stress, one of the things that is a criteria for it is avoidance, right? Or numbing out, having these re-experiences. Now, if I'm struggling with getting pregnant, I may start avoiding my partner. I may start avoiding sex. I may start avoiding going to places where I know there are going to be people. Anything that's going to be a trigger for me. I may start having recurrent dreams, flashbacks of my loss, or flashbacks of this doctor's visit or calls like that. To go all the way back to your question, the mental health impact can vary. It can be a wide range. You can have all of those symptoms at any given point. The anger that comes with it too. So it can manifest in many different ways. And what I'm talking about, it doesn't mean that everybody who has infertility or struggles with infertility is going to have some psycho-emotional or mental health impact. But it can happen. And I talk about this because sometimes people don't even realize that it's happening, because you're just like, go, go, go. Okay, well, my cycle started, my period started today. Oh, well, okay, I got to try again this month so I can get ready for next month. And if you're doing infertility treatments, those people know that you have like this window. So, day 3, I got to go to the doctor to get this and see what my hormone levels are. So you don't have time to really fall all out and grieve and be sad, because you got to pick it right back up to keep it moving and start again, hoping that this month will be the month.
Right. Wow. And I remember watching an interview with Dwayne Wade and Gabrielle Union when she was talking about their process, and he was saying how it just really hurt him to see her going through it. And she had just actually become so numb to it. And he was just saying he was no longer enjoying the process because it just looked like it was hurting her more than it was helping. Made it more like a job to get pregnant than them trying to enjoy the process, and just the whole mental and physical impact of her body of trying to do that. So yeah, I'm sure the mental and emotional part of it is probably more devastating than the physical that we could see.
Right. Because your mind is always on it for the most part. Once you have received an infertility diagnosis and you maybe at this point are working with your doctor to try to conceive, and you have maybe some type of medication protocol, it's very rare that you're not thinking about it and that it's not on your mind, because you have to take maybe a pill or do some type of injection, or you are constantly now aware of your fertile period. Am I ovulating? When is my peak? Are you going to be home at my Like, let's get it. We're going to this enjoyable moment. And not to say that it's not enjoyable, but your mind is there.
Right.
Did I keep my legs up? Did I lay down?
On demand sex, yes.
Right.
All right. So that's good. And as far as support systems, I've had friends that have experienced loss. I've also had a friend, she was trying to conceive. And just not knowing what to say. And sometimes it's more of an avoidance, or what questions do you ask or shouldn't you ask? So as far as mental health and making sure, as far as like support systems, understand what someone would need or wouldn't need, do you have any kind of advice for us?
Yeah. Look, yes. People are different, right? And so one person's needs may be very different from the next person's. You may have 2 friends who both have experienced the loss, both are seeing a reproductive endocrinologist. One may be okay with talking about her process. The other may really struggle and shut down and disconnect. One may be okay with you saying, all right, girl, we're going to try again, come on. The other may not be okay with you saying that. But some of the things that I think the support system can do is ask, how can I support you? And doing that, not supporting in the way that they want to support, and being okay if the person says, I don't know. Being okay with if the person says, I just need to pull away, or, hey, no, I can't come to this baby shower, or no, I don't want to go to church on Mother's Day. I'm logging off social media. And so I think the support system can realize that and take that into consideration, but also being very careful and mindful with, well, this is what's just meant to be, or it's God's will. And although a person may rely on their faith or their spirituality, sometimes when you are kind of going through this, that may be rocked or shaken for you. And so you may not be rocking with God right now.
Right, exactly.
Not trying to come up with answers. Well, or just relax. That is the one that I despise. Okay. Do not tell somebody to just relax. Because trust me, we did. It's like if you were going to work every day and not sure if you were going to lose your job, would you be able to relax every day going to work? And how would you feel if every day your friend or support system said, girl, go on in there and just relax? Well, no, I'm going to be anxious. I'm going to be a little worked up. And I don't want you to dismiss the feelings that I am having. And I am scared, or I'm anxious, or I'm angry, I'm frustrated, I'm confused. Certain infertility medications can impact your obviously your hormones, but how you may respond. So they may be a little snappy. So definitely that whole just relax. Don't go with that. I'm telling you, if you want to keep your friendship,
don't say
situationship, your family ship, don't be coming in there telling somebody, because trust me, we have tried it all. What would people say? Oh gosh, are you doing it this way?
I can imagine.
You do know what it takes to make a baby, right? Like, nope, I don't.
Yeah, especially those older relatives, I can imagine.
Right. Being just aware. And I don't think that a lot of the comments by support systems are ill-willed or have some type of negative intentions behind it. I think we do want to celebrate people. We do want to see, like, if you're in a partnership, somebody may say, oh my gosh, when are the babies coming? Mm-hmm. Or, oh my gosh, when, where's my grandbaby? Where's my little niece? And, things like that. Not really understanding that, trust me, this person is trying everything that they can. They're spending thousands and thousands and thousands of dollars. They're taking off work. They're going to the doctor. They're getting poked and prodded and blood drawn, teased, massages. They're doing all of these things. So just being careful of that. If they are vocal about their journey. We weren't as vocal about our journey with a lot of folks. We had people that did know and supported us, but if they're not vocal with their journey, letting them be okay with that, you being okay with that. And if they are vocal, again, just like, how can I support you? If you need me, call me, but then you don't answer the phone.
Right. One of the things that you said, and I know it's a fine line, when you were saying a lot of times people pull away and just kind of want to be to themselves, that can be good and that can be bad. So from a support system point of view, is there additional signs that you may need to look for? Or do you I'll give you 24 hours, to check in? Because I know for me, as far as depression, when I get depressed, I do want to be alone. But then sometimes in that loneliness, it makes it worse. And it's weird because you want to be alone, but you don't. So it's that
somebody came in and got you.
Right. So I can tell you to get out. But just
right. You're right. I have a great group of girlfriends, and whatever I was going through, it wasn't necessarily just infertility, but they would say, look, don't answer this phone one more time, or don't respond to this text message one more time, like face, and I'm gonna keep checking on you. But if I don't hear from you after a certain while, understand we're coming to your home. And I knew they would. And I appreciated that. Mm-hmm. And so I knew if I just still didn't want to be bothered, it would behoove me to reply and say, y'all, I'm good, or just pray for me, whatever I may have needed at that time. But if you are, so let's just say it's a spouse or a parent, and they are directly seeing the mom, the intended mom, the hopeful mom going through this, knowing some of the signs and symptoms of depression. So the isolation, no longer enjoying things that they used to enjoy. Because isolation, again, doesn't necessarily mean I'm depressed. Not wanting to go, I love crafting, I love gardening. Not wanting to go craft doesn't necessarily mean I'm depressed. But if it's happening constantly, if you're starting to see a change in their eating habits, whether they're not eating at all, or barely eating, or whether they're now overeating, and that emotional eating piece that comes with it, a change in sleeping patterns. Are they sleeping all day, not getting out the bed, calling out of work? If they already have another child, are they not really attending to that child? Or are they just like, Lord, I just can't wait till the day ends so I can get right back in this bed? Are they not sleeping? Are they up 2, 3, 5, 7 o'clock in the morning? I had one lady tell me she did not sleep for 48 hours. And I just looked and I said, all the way through? Right. Did you get a nap here and there? Right. And the answer was no. As a clinician, I know that that's teetering on not being good. We have to sleep. We need sleep. So those are some things to look for. And I also think being able to, when the person that's experiencing the infertility is in a mood or have in a position where they do want to talk, again, asking them, how can I support you? What will be some ways that I know that I need to now intervene, or I need to kind of come really make sure I'm checking on you? If the person is talking, suicidal thoughts, if they're just like, I don't want to be here no more, and I don't care if I wake up in the morning. And that doesn't mean you need to go call 911 at that moment, but you do want to just kind of look and see. You may want to suggest that they go ahead and get to a therapist or get to the hospital, just so it does not keep building up.
Okay. And it's great that you actually said that, because that's another question. We talk about getting help, or we see these things or see these signs, and it's like, well, you need to go see someone. But who's that someone? Who do I need to see? Where do I need to go? Or if you're experiencing this and you realize, okay, something's not right, I'm not myself anymore. Like, what are the next steps?
Because I am a clinician, I am always going to advocate, right, and suggest getting a therapist. But I tell my clients, like, look, everything does not require therapy, honey. You don't need to be in here long term. Let me kind of help you get back on track and keep it moving. I also am a proponent that you go to therapy before things pop off. Right. So I tell people, you don't wait till your engine locks up before you go to the mechanic for an oil change and a tune up and a transmission flush. Right. You don't wait till you pass out and stroke out, for the most, but for the most part, you don't wait till you stroke out before you're at your doctor for your yearly physical. Mm-hmm. And especially if you work for a company that tells you got to get those physicals or your premium is going to increase. Right. Mm-hmm. So you don't wait for any of that. Don't wait till you are suicidal, homicidal, can't function before you go to a therapist, right? Mm-hmm. Like, even if you just need to go to, like, hey, I just need to talk. Life is life. I mean, it doesn't mean anything is wrong when you're seeing a therapist. It just means that maybe you're wanting to be proactive. So when life happens, because I always say life be lifing, right? When life happens, you are in a better position to kind of cope with it. So I'm always going to say, go to therapy. So when you're seeing that, definitely start saying, okay, let me reach out. Let me go ahead and connect. Now, for some people, that may be before they even get diagnosed with infertility, because maybe they are really struggling, really sad. I don't have a purpose. I don't have a value. I don't know what to do. For other people, it may not hit them until they have this diagnosis. Now it becomes real. Mm-hmm. Right? Like, somebody has put something on paper that says that I cannot conceive, or I'm going to struggle conceiving, or I'm going to need medical intervention to conceive. It's here in black and white now. I always, when I connect with infertility clinics, I always suggest have a referral list for mental health providers. When you're giving your patients this diagnosis and this paperwork and do this, and that, you also need to say, and here are some clinicians.
Yes.
Here they are, because people don't know where to go. So I did my dissertation research on, long title, mental health help seeking of religious and spiritual African-American women diagnosed with infertility. My title. And what I really was looking at, obviously, is the psycho-emotional impact of infertility. But what happens for Black women that, mental health issue, right? They're religious and or spiritual, because now you have another context in there about what your religion says about children and conceiving. And now you have infertility. And so we know in the Black community, there's stigma when it comes to mental health. There's stigma when it comes to infertility, what folks believe culturally, what society has said about the fertility of Black women, or you're supposed to be hyper fertile and all this and that. Or, even if you have your own beliefs, like everybody in your family, they'll say, girl, if I just get looked at, I get pregnant.
Yes.
And now you're like, well, wait, everybody in my family but me? So that was my research. I had 33 women want to participate. I interviewed 16 women. 12 made it into my actual research. Out of those 12, only 3 went to therapy. And I actually interviewed some therapists.
Wow.
Or people who knew about the benefits of therapy. One of the things that they said was, I didn't even know I could go. I didn't even know therapy existed for this. Like, I see therapy for you're a widow, like grief and loss, right? Mm-hmm. I see therapy for drug addiction. I see therapy for parents with special needs children. Like, I see all of this, but I never knew that I could find a therapist who specialized in maternal mental health, or who specialized and understood infertility. I don't want to go to a therapist and now have to sit here and explain what infertility is, explain the terminology, explain what I mean when I start saying POAS or PCOS and PTC, all that. They looking at me like, huh? Mm-hmm. I don't want to explain all of these acronyms. And if I'm having to educate you more than what I'm getting to help, what's the point?
Right.
So that's what my research did. And like I said, it was that they couldn't find anyone. They didn't even know. And they also did not feel that they had clinicians or could find clinicians that looked like them. So again, I was talking specifically to African-American or Black women. And so that was another thing that kept them from going to therapy, because now how am I going to feel, or am I going to feel comfortable talking to someone who I may not feel I can connect with, or who I may not feel will understand me? So they're not going to understand infertility. They're not going to understand me culturally and why this is an issue for me. Mm-hmm. They may not understand how I really do rely on my religion and my spirituality, and I need that incorporated into therapy. So again, what's the point?
Right.
I can do bad all by myself type thing.
Right. It just makes you feel worse, or going through that process. A follow-up question to that: if I'm feeling bad, I'm feeling low, you see titles like counselor, you see titles like therapist, you see psychiatrists and psychologists. Whose door, or do I go to my primary care physician? Whose door do I knock on?
Right. Absolutely. What my research also shows out there is, especially in our community, the first person we're going to go to is our primary doctor, which is why our primary doctors need to be armed with referrals and resources.
Right.
So could they prescribe me some medication? Yes. Could they kind of help me get on track? Sure. Do they specialize though in mental health? No. So the way I try to help people understand is, if you go to, let's just say you're pregnant, right? And you say, oh man, my stomach gets kind of tight. You go to your primary doctor. Your primary gonna say, oh no, honey, you need to go to your OB, your GYN, or your maternal fetal specialist, something like that. Now, could they run some tests? Absolutely. Are they the specialist in that? No. And if you said, oh, I get these cramps in my stomach and it feels like my heart skips a beat. Oh, so now they could probably send you to the cardiologist too, right? Could they take this blood work? Absolutely. So it's the same thing when it comes to therapy. Can your doctor prescribe you medicine? Yes. Will a psychiatrist, though? So a psychiatrist, to answer your question, is a medical doctor, but they can prescribe psychotropic or medications for mental health. They also are going to have a little more training. So they're going to know if some medications should not work together. They're going to be able to ask certain questions to say, oh, wait, this is really anxiety. I need to give this person an anti-anxiety, or I need to give them an antidepressant, or this may be trauma. Let me send them to a therapist. And so while your medical doctor or your PCP can give you, let's just say Xanax, but if your true issue is not anxiety and it's depression, that Xanax is probably really not going to work. And you're going to be now still thinking even more that something is wrong with me, because here I am now on this medication and ain't nothing working. So I can't get pregnant. I can't get right on this Xanax or this Zoloft or whatever it may be. So a psychiatrist is a medical doctor that works mental health related, can prescribe medication. A psychologist is going to do, so many psychiatrists don't do therapy. They're going to be far and few between. Can they do some? Sure. Most don't. They're going to be in the business of helping you with your medication management, psychotropic medications. A psychologist does more testing. Some do therapy as well. And then counselor therapist. So folks use that term interchangeably. You may hear therapist, you may hear psychotherapist, marriage and family therapist. Me, I'm a licensed professional counselor. You'll hear social worker, all right? A LCSW, licensed clinical social worker. Those are going to be the folks who are going to be helping you with that talk therapy, who are going to be helping you develop coping skills, who can help you resolve maybe some childhood issues, some depression, who can help you kind of get to the root of why you may be doing certain things. That would be the difference. And sometimes, in my experience, it's best to even coordinate. So I may be doing therapy, but I also may know that, my client is severely depressed. And what I am saying, they're not even in the position to receive it, benefit from it, to hear it, to apply it. The only way they are going to kind of start getting over that hump is they may need to go see a psychiatrist for 30 days, 60 day, 90-day prescription. So I can get their chemicals and those neurotransmitters and all of those other things that are going on. The medication can help with that. And then now as I'm doing the therapy, it's easier to receive. It's easier to do. One of the things that I'll never tell a depressed person, me as a clinician, is, just let's get up and be active. Let's go exercise and get those feel good hormones going, get those endorphins. Is even from my own experience and my clients' experiences, is it's a struggle for me to get up and go to the bathroom. And you want me to go to the gym and get some chemicals?
Right.
Oh, I'm on this couch or I'm in this bed.
Yes.
So here again, it's almost, well, just do this. Trust me, if that was going to work, I would have been done it and I wouldn't be in here in your office.
Right.
So now, can it be beneficial? Absolutely. When my clients can get to that, that is definitely something that I suggest and we talk about. But so sometimes though, it is good for me to kind of coordinate this. I may need to send them for a psychological because maybe I feel like they need a more in-depth testing. If I'm kind of seeing something, I'm not too sure about their diagnosis. So I need, a second opinion, so to speak. And I need the psychiatrist involved. And if they're seeing an infertility doctor, I may need to be involved with that too, so that I can help them understand what's going on from a mental health aspect. And I can also know medically what's going on with them. So I can even know how to help them in therapy. If the doctor is saying, hey, I'm going to have to take out your uterus and we got surgery scheduled, it's not going to benefit me to talk about, certain things. It's going to benefit me more to talk about maybe some of the grief and loss, or a person needing to pre-grieve. Like now I have to even pre-grieve knowing that this is getting ready to happen. I can't give them these false hopes or help, have them thinking in a manner that's not going to be beneficial.
Right. And so this coordination of care doesn't seem as if it's done.
Correct.
Is it because the patients don't know what to ask, or is it from the doctor's side, or is it a combination of both?
It's a combination. Sometimes the patient or the client may not know to fill out a release of information. They may not even understand that medical and mental health. So again, when I'm talking about some mental health issues, a lot of mental health stuff is manifested in a medical or somatic way. I'm going to my doctor because I'm having constant headache. I'm going to my doctor because I'm indigestion or stomach problems, whatever it may be. What's really going on is perhaps I'm depressed, I'm stressed, and I'm having all of these migraines or these headaches. I'm not taking care of myself from a mental health standpoint, and it's affecting me physically. I'm not taking care of myself from a physical standpoint, and it's impacting me from a mental health standpoint. So sometimes they don't even know. They're just like, no, I need to go to my regular doctor. I have headaches or I have stomach aches or whatever. So they don't know the benefits of doing that. Other times, sometimes some professionals may not want to talk to another professional. Other times their schedule just does not align with it to sit down and have a conversation. You think about when you go to your primary doctor. They're seeing you, say you hear them in the next room, wrapping up with the next patient and the next and the next and the next. They're filling out this, they're trying to keep it moving. And it's not always as easy to say, hey, I'm going to see my therapist at 12. Can you get on the phone and talk to her, about X, Y, and Z? It may not always be feasible for the therapist to stop and have some time to call the doctor or a client. And so sometimes it really does take a little more work and a little more effort to kind of coordinate that care. It's just a matter of, one, if the patient gives that release of information for that to happen, and then two, if the other professional is okay with it and available to allow it to happen. If they cannot have actual conversations, sometimes I may say, well, can I get a copy of your records and look at them? The client may request for me to send my records over to their medical doctor or even to their psychiatrist, so the psychiatrist can see know what I'm seeing, and then they can help assess if the medication that they've prescribed is beneficial or if they should change it.
Right. And I know you said you were hosting a webinar in August about grief and loss. And so from a patient point of view, and just understanding, like you were saying, that if I'm going to my reproductive doctor and I'm working on all these things to try to have a child, and then I may be seeing you as my therapist, what are some things that I, as the patient, need to make sure that I'm asking or transferring to each of these? Because like you said, it's our responsibility for our own mental health as well as physical. We do have these professionals, but what should the patient be doing or saying, or what questions or things should they be asking? And
you're talking about like saying to maybe their reproductive endocrinologist and to their therapist about their process?
Yes.
I'm not going to say any shoulds, because that would almost imply that perhaps the reason they're not getting pregnant is because they're depressed, right? Or the reason they're not getting pregnant is because of some other mental health issue. And we know all day long people with all types of mental health issues get pregnant, right? But to kind of help us, I will say the shoulds are more of how can I advocate for myself? What do I need to know? How can I teach my clients to have a voice? So yeah, these doctors, we're experts, but you're the expert in you. Mm-hmm. And guess what? You paying for this time. So no, Mr. and Miss Doctor, explain to me what you mean about low ovarian reserve. Because I don't get it. All I know is I'm having a cycle. What you mean I'm not ovulating? I have my period every month,
Right.
So kind of being able to know to ask those questions, and that it's okay to advocate for that time. But then also is sometimes, although depression isn't going to be a cause for infertility, maybe the depression is so severe that the person cannot engage in sexual intercourse. They're not doing that. Or we do know that brain chemicals and things change and things like that. So being able to talk with their reproductive doctor and say, like, hey, I am on an antidepressant. I have been diagnosed with X, Y, and Z. So again, that doctor can see like there is still a psycho-emotional, there is a mental health impact when it comes to dealing with infertility. And again, so the therapist can also know what is going on. How can I help you in our therapy time based off what the doctor has said, has diagnosed you with, so that I can kind of help you prepare for that, or help you work through that, or even help you grieve through that.
Right. So as a patient, if I know that I'm going through these kind of issues, what should I be looking for in a therapist? Because I think that's a lot of times not knowing what to look for or what the qualifications are. So if I'm looking for a therapist and I'm having infertility issues, I'm going through this grief and loss, what should I be looking for in a therapist so that I know that they would be a good fit? Because like you said, it's not many of people that actually specialize in this specific area. So what should I be asking?
Just that, what is your experience in working with women or men or couples with infertility? What is your experience with postpartum depression? It's going to look different from, I don't want to say regular depression, but it's going to look different from maybe a different type of depression, right? Even knowing about maternal mental health, because a lot of times in society for folks that are untrained, they say, oh, well, postpartum is going to happen within the first 6 weeks. And if it's after that, then it's not postpartum. Well, that's not true. Okay. That's not true. So if I come to a therapist 3 months after I've had my baby, it just started. I had my baby 3 months ago. If I'm not trained and not know that, I'm going to misdiagnose you, right? Which is not okay, because now again, I'm not treating you correctly. So some of the things that people can look for, if it's a Google search, Googling therapist infertility, like those two words. Because many therapists that have specialties, they put those specialties in their keywords. So when folks are searching for them, they can call. And so if they find a therapist or see a therapist that they really feel like they may like or accepts their insurance, they can call and ask and say, hey, does this therapist, if they have a scheduler, does this therapist specialize in this? Or I was wondering, do you have any therapists that work with postpartum depression, maternal mental health, perinatal mental health, reproductive loss, like whatever that is, and then get hooked up with that clinician. They can call their insurance company. So when we get on insurance panels, we put what our specialties, what our areas are, and the insurance company puts a little, list and all of that. And so if I call my Blue Cross Blue Shield and say, hey, a therapist that sees children, I need a therapist that works with infertility or women's issues, they should be able to help give me a list for that.
Okay. So I'm in Monroe and I want to see Dr. Christie, or if I'm in an area like Monroe and they have none, is it better to see a therapist face to face, or can I see Dr. Christie, because she's the greatest and she's in Atlanta? So what does that look like? If I'm looking for someone in my area, is it even feasible for me to reach out to you in Atlanta, something like that?
The way it works for distance counseling, you have to be licensed in that particular state where your client is. Okay. So I'm licensed in Georgia, but I'm not licensed in Louisiana. So I would not ethically be able to provide you with counseling and legally too, because if you decide to sue me, honey, I'm going down.
Right. So is it a therapist phone book or, something like that?
So because you're right, sometimes folks are in rural areas or they're in areas that are not highly populated with clinicians. And so we come into this whole access to care, right, issue. And so it is really a struggle for them to find someone. So perhaps maybe you can't find anyone in Monroe, but you can find someone in New Orleans or someone in Grambling or Shreveport or wherever.
Mm-hmm.
And if they're trained and can do distance counseling or telehealth or telemental health, then yeah, absolutely, you can see them. Now, some clinicians may have a process, or some counselors may have a process on who they do see for distance therapy. Like for me, I have to definitely make sure there is no risk of harming themselves or someone else. And sometimes if I am not seeing you and I don't know your personality, your movements, your styles, I don't know that as soon as we hang up, this video goes off, that I may not see you again. So for me, I typically will only see clients via distance when I know, and I've had a moment to in office assess them and get to kind of learn them. To learn when that head does that,
right. What does that mean?
Quiet. But then others are like, no, hey, I'll just see, as long as I can verify that you are actually Shayla and not Stephanie, and I know your support system, I know your emergency contacts, I have a protocol if I cannot get in touch with you, things like that. Some are okay with that. But yes, definitely Google searches. There are therapist directories like Therapy for Black Girls. Some folks use Psychology Today. Some folks use like Open Path. There are so many different ones where people can do like some Google searches. And again, contacting their insurance company as well if they are using insurance.
Okay, that's good. And I know your focus is more on African American mental health and infertility. Was there a reason why you decided to have that focus?
Absolutely. Most definitely. Again, like I said, my own personal experiences. So when anybody that's done doctoral research or gone through, when we get to that dissertation, they always tell us, well, where's the gap in the literature? What is missing? We already know that Black people tend to not go to therapy as much as their counterparts. So I can't research that, right? Not contributing nothing new to the literature. We know that there is a high religious or spiritual significance in the lives of many Black people. So I ain't adding none to that, right? But what I did not see was, at the time that I did my research, any literature that combined all three. So mental health, religion and spirituality, and infertility. Now that's a problem, because what we also know is that Black women are diagnosed 1.5 times more, or they're 1.5 times more likely to have an infertility diagnosis than their counterparts. So that tells me we got higher rates of infertility. We have similar rates of mental health issues, but nobody is looking at anything. No one is talking about it. No one is studying it and researching it. Again, based on historical issues and historical traumas and historical neglects and disparities from a mental health and medical standpoint, a lot of times Black people not trying to contribute to no research, because the time that we have, we wound up with dead from syphilis, or forced sterilization, or over-medicated, under-medicated. Research has also shown us about the implicit bias where some medical professionals feel that Black people have higher pain tolerances, so they're not given medications. So people not trying to be out here being researched, I found the value in what I was doing, and I was so thankful for every single person who reached out to me and contributed to my research, because without them, I would not be Dr. Holloway, or it probably would have taken a longer time to get it. Another reason why I did it, and I tell people, I challenge them every time I talk about infertility. I tell them, I say, get out your computer, get out your smartphone, whatever, and I want you to just Google infertility in women. And I want you to click on images, and I want you to tell me what pictures you see, okay? It's not going to be of Black and brown women, not as much. Now you're in a very diverse place, and you can only find 3 people of color, and I knew they were stock images.
And do you think it's more because we don't have those conversations that?
Yeah, I think it's because we don't have the conversations. I also think there's bias, there's racism, there is neglect, there are disparities even in research. There's this in medical treatments. Typically, infertility has been viewed as a wealthy white woman's disease. babies.
Right.
So a lot of the research is on white women or white couples or middle class couples. But here's the thing, infertility doesn't discriminate against race, socioeconomic status, religion, sexuality, sexual orientation. It does not. And so if a lot of the research is only focusing on a particular group of people, or if my doctor just said, oh my gosh, I'm so sorry, I'm going to have to diagnose you with infertility. And I'm like, what? I don't even know what that is. Because, hey, all the women in my family get pregnant. Let me go Google this. And then I go Google it and I don't see nobody that looks like me.
Right.
Or I go now to an infertility clinic and a lot of doctors have pictures of their successes. And I don't see many Black and brown babies. I'm now stigmatized. I feel alone. I don't feel like anyone understands. And so this is why I had to go and research this and talk about this. One, to get the conversation started, because we're experienced with infertility. Like I said, I just did this forum on Saturday and it was well attended. And I know just that I could think of at least 4 women came up to me with infertility issues.
Wow.
Hadn't talked about it, right?
Right.
Young, middle-aged people who were saying, I'm still grieving 25 years later. There is still a desire in me 25 years later, having no cycle, nothing, to be a biological mom. So I wanted to research that because, again, to start the conversations, to start to dispel the stigmas, to get rid of this myth that Black women are hyperfertile, super fertile, reproducing, making babies, to get rid of the myth and the stigma that infertility only impacts wealthy people, less melanated people. Like, it's just not the case. And I think by doing this is going to heal a lot of people, change research, change medical practices, change the way that medical and reproductive doctors consult with their patients, change the way patients now go to therapy, and it'll be this holistic view or this holistic treatment of a client. Me as a clinician, even when I'm not talking about infertility, one of the things that I always ask my clients is, tell me about your religious or spiritual beliefs, your religious or spiritual practices. How is that important to you? Because if they told me that this is important and they talk about it, then I know that has to be incorporated into the treatment. I cannot neglect that, because if I'm neglecting it, I am not treating holistically. I have put to the side something that is extremely important to you that gets you through.
Right.
So I'm not treating them holistically. And I think by doing this, it's going to take a holistic approach to helping women that are experiencing infertility.
Great. That's amazing. So for everyone listening that wants to get more information on your research and what you're doing when you're speaking, can you go ahead and give us that information?
I sure can. You can definitely go to my website, which is ChristyCHolloway.com. I am on Facebook under Dr. Christy C. Holloway, Instagram, Dr. Christy C. Holloway, and LinkedIn, Christy Christopher Holloway. So that's my professional and my speaking and training site. And then for counseling is newvisioncounselingcenter.com, and they can reach there. I own a group practice. So if a person can't get with me, I have several great clinicians that they can get with. And I have 2 other amazing female clinicians who work with infertility and maternal mental health as well, which tells you how important this is.
Absolutely.
Because it was getting to the point where I couldn't even put everyone on my schedule. And I had one person come on and then I had to hire a whole nother one. So people want to talk. People dealing with infertility and maternal mental health want to have someone to talk to.
Right. We can actually talk to therapists.
Yes.
We can actually talk to our friends. We should actually be having this conversation. And this is exactly the reason why I wanted you on, to start these conversations. Also to make other people feel more comfortable with engaging in conversations with friends or family members who may have infertility issues, who may be grieving or going through a loss, so that we understand what they need and we don't just shy away from those conversations and stop inviting them to things. Because like you said, everybody handles things differently. And the only way you will know is ask, will you be comfortable coming to the baby shower? They may want to come and we're just not asking because we feel like they would be uncomfortable. So thank you so much for coming. This was amazing. Thank you
for having me. Look, I will come back anytime. I done got hot over here. This is my passion.
So I will definitely hold you to that. So thank you so much, Dr. Christy.
Thank you. Thank you, everybody, for listening.
Thank you for listening to the Navigating My Crazy podcast. Don't forget to send all of your questions to questionswithan@navigatingmycrazy.com. Also, join the community and chime in on the conversations by liking and following Navigating My Crazy on Instagram, Facebook, and Twitter. Moms, have a great week and get ready for our next Talk It Out Tuesday.